across the system, that we do need to do more collectively to address the shortfalls in the experienced workforce, to provide the expertise to manage this particular presentation. We have seen a slight reduction as well in some other areas in the focus through August. I think primarily that is temporarily. It's connected to, obviously, there has been a high level of annual leave through August. So through the Deputy Chief Operating Officer, we continue to have really robust mechanisms in place to manage and really sort of review the data in relation to that, and obviously take action where required. So I do expect that to recover quite quickly. But it does remain a challenge for the reasons that I've discussed. Demand obviously has plateaued, but it's plateaued at quite a high level across the board, again, particularly in CAMS. So our preparations, obviously, for the next few months are to really ensure that we've got sufficient capacity and that we're addressing that where we can. But I'm really happy to answer any questions in relation to that.
Okay, thanks, Lynn. Did you want to say anything more, Pete, before we open up for questions?
Sorry, Chair, I was on mute. Happy to move straight to questions.
Okay, lovely, thank you. Right, who would like to kick off? Could I just ask a quick question, Lynn, before I bring in Peter? In terms of the waiting list trajectories, obviously we have a sort of, it's based on staff undertaking 30 assessments a month in Hull, and I think it's 20 in East Riding. How is that happening in reality, and will we get a sense of that?
So specifically, we are managing to meet that, Caroline, by and large in Hull, which is how come we're managing to achieve the trajectory that we set out. For the reasons that I've said in terms of staff absence, we're not meeting that currently, or haven't done in August and September for East Riding due to that absence. But as I say, that's why we've increased the capacity in the digital platform that's available to us. We've done some very specific work really around skill mix in that service as well, in order to make service more robust in terms of covering those gaps in absence. So our expectation is that we can quickly get back to the position of meeting that 20 assessments capacity that we've set.
So you're saying, actually, I mean, given all the different, thank you. Okay, Peter.
Thanks, Caroline. Yeah, it's really useful to have that update on the waiting lists, Lynn, and thank you for all the extra information that you've given us. I was going to ask some questions, but you've covered them. Thank you. The only thing I've really got is just on the dashboard on page 75 then, and to note a couple of things, because first of all, the indicator totals on the right-hand side, there are no red flags. I think that's the first time for a while I've seen no red flags on any inpatient ward, so well done for that. And also to note another good stat on there, which I perhaps highlight, agency. All the arrows on agency fills are downward, so that's good to see that maybe those shift to think workers or through bank. So it's great. But when I consider the whole performance indicators, I'm looking for something which gives me some comfort on doctors and consultants, and perhaps some information which details any vacancies and how those vacancies are going to be filled. And there's nothing really there. I mean, we've got nurse vacancies there, but there's nothing really here which tells me, and I know there are like vacancies at Inspire, there's vacancies for GPs in the GP surgeries, etc. So I just wondered if the execs could perhaps think about whether or not there's something which they could develop. I'm happy to consider taking something away as well, but where we don't talk about some of these charts quite so much, but certainly on the consultants and the GPs, what the situation is as regards vacancies and appointments and what's in the pipeline, etc. So to give us some information on that, because it does affects quality in terms of continuity of care if we're using locums a lot. And also impacts on cost if we're using locums and agency workers rather than our own substantive staff.
Thanks, Peter. Would anyone like to come back in on that? Steve?
Shall I start that one off? It's a really good point. We've just done quite because obviously, if you remember, we did a piece of work with the team about nursing staffing or general staffing levels, which obviously we'll continue to work through. We'll be picking that up again at the exec team. John and Kwame have done a piece of work in relation to medical staffing, so we've got quite a lot of detail now about each of our posts, where they are in the system, vis-a-vis if they're agency, etc., and what a little bit of the future projection is in relationship to those. So we'll be discussing that in a lot more detail at the executive team in the next couple of weeks. But I think we've probably got a bit more of a picture now, Peter, than we had before. And then I think it's something that we can get into the workforce committee for a bit of assurance. If you remember, the committees are for assurance. So I think if we leave it with ODG and then EMT, and then we'll put it into the workforce and OD committee. But that works. Because I think you're right, because we're spending a significant amount on agency as well. So I'm happy to share what we've got in the meantime. But unless John or anybody wants to answer it, or Steve wants to come in, I'll leave it there, Chair.
Okay, thanks, Michelle. Steve, John, I know John's put something in the chat box that there's a lot of data covered at Workforce and OD on this issue, and maybe it's a way, based on what you've just said, Michelle, to pull out some strands from that we can sort of think about and be highlighted up to all of us. John, did you want to come in on that recruitment, doctors and consultants?
I'll let Steve go first, Chair.
Sure, Steve.
Yeah, thanks, Caroline. Thanks, Peter. So, consultants is part of our hard to fill task and finish group, which we bring a report to Workforce and Committee on that each month, each meeting that we have. There's a plan there. We monitor the performance. We look at the overall data on that and how we're progressing against it. So it's all there, Peter. I mean, if that's about moving this into this report, that's a very easy thing to do. We have access to that. I mean, maybe something for Dean as chair of Workforce Committee, happy to go into more depth if there's a feeling that there's more needed to be done on that. What I would say is that between John and myself, there's a comprehensive plan in place to recruit. We were successful in recruiting consultants recently. So I'm assured that work is going on to do what we know is a really tricky market to try and recruit into. But we have all of that data, Peter. We report it into Workforce Committee. So very happy to bring something here if we need to, or talk at more depth at Workforce Committee if that's the ask.
Okay, John, did you want to add anything to that, John, or?
No, just to reiterate, Caroline, what Steve has said, and that is backed up by a comprehensive recruitment campaign which has been supported by comms over the last year. So, interestingly, Pete, when we look at the details of our consultant sort of staffing over the last 4 years, we have had a turnover, but we've actually brought in 10 or 11 new consultants who tend to be younger age. So in some ways, we're solving some of the problems we're going on with regard to an ageing workforce. And the thing about sort of consultant and GP vacancies, as we see as the workforce data, is they do go up and down. And it is part of a wider national problem. But dare I say it, I think we're chucking a lot of expertise and resource at it, which is covered off in workforce and OD.
Okay.
I just think that I know it's such an important area. I do think we should give consideration to whether one page in the performance report should be given to this in such an important area. I mean, there's so many pages in the performance report, and this is such a key area compared with, I know there's a lot of key areas here, but I do think the board should see the trends and be able to discuss the some of the things which you've just talked about at this level, rather than just at the Workforce and OD Committee.
Yeah, I think that's a valid point, and I'm going to bring Dean in, and I think I mean, obviously new to this job, I don't think we want to duplicate the really extensive work that the subcommittees are doing and the details there, but I think a sort of sense of, as you say, Peter, the trends about what's happening might be helpful, but we can maybe have another discussion about this outside the board, and I'll hand over to Dean. I know he's probably going to have all the answers for us. Dean.
Certainly not got all the answers, and happy to speak to Steve and Peter about whether it's more information in the insurance report or we put something in the board report. I think it is useful, Peter, isn't it, to sort of pick up some of the areas. I suspect that it may not have been highlighted as much because it's been an improving position, I think, through the Task and Finish group in terms of the number of nurses and doctors we've got in post rather than a deteriorating position. So I think there is some positive news in there, which might be why we've sort of not highlighted it as much as we might have done had it been going in the opposite direction. So very happy to pick up on that. I had got an unrelated question, but I'm conscious, Caroline, that there were other people ahead of me for that, so I'm happy to come back in as appropriate.
Okay, I'll take Francis because he's been waiting a long time, and then come back straight to you, Dean. Francis.
Thanks, Caroline. And just to finish off on the discussion we just had, I was going to raise a bit later on under the standing orders bit, and we can maybe do it in part 2 about what comes to board and what comes to committees, because we've got a very full agenda today, and a lot of that has been through committees. So it's just a question of maybe outside of board reviewing that. My only question, because Peter's picked up on a couple of mine, was the only, there's some great performance in here. The only one that's slightly worrying continues to be the out of area placement, which does seem to be continuing to rise. I understand the issues behind it, Lynn, and the problems we've had with beds and everything else, which we discussed earlier, but just wondered where we were going, particularly if you look at the older people one, which definitely does seem to be going up and might be difficult for people to get to.
Lynn?
Yes, thank you, Chair and Francis. So, Francis, obviously the Maester beds and the opening of the up to 5 beds there, obviously our expectation is that will make a big difference in terms of meeting our demand for older people's beds. In terms of, we saw a rise in use of out-of-area PICU beds and to some degree mental health beds too. The factors that I've already touched on today did have a obviously direct impact on that. The fact that we had wards closed for periods of time due to infection control because of the COVID positive patients, and at the same while, I think we've quite rightly continued our programme of estates improvements to our inpatient estate, and that particularly impacted on Avondale and the PICU as well. Obviously, those works will have the benefit of improving, the environment for both our service users and our patients and our staff. But obviously, that work is now complete. So, we do have a trajectory in which to, eliminate the out-of-area beds as quickly as we possibly can. We're required to do that nationally as well. Set out a paper to EMT recently. We've reviewed the beds that were not available due to the COVID safe working arrangements, which has meant that we have been able to increase the bed base now in Avondale, particularly, and elsewhere. So, with all of those factors sort of that work complete, obviously the ongoing impact of infection control to some degree, we'll do our utmost to prevent that, but I can't give guarantees that won't happen, which unfortunately obviously does lead us to need to use beds. We still do have some blocked beds as well. So in terms of the patient user experience, that when we need to access them, we can generally do that quite quickly, but obviously our aim is to eliminate those overall. So we are working absolutely to address that. We do have robust plans in place, but for those reasons, they have been impacted over the last month.
Thank you, Lynn. Is that all right, Francis?
Yeah, that's great, thanks.
Thank you. Dean?
Thank you. I just got a question just around the 52-week waiters, and apologies if I missed it, Lynn, in your update. My internet was a little bit in and out as you were speaking, but it was just that I wonder if we could get a sense, maybe not for this meeting, but maybe through quality or another meeting, about the longest waiters. So although we've got the national target of the 52 weeks, haven't we, in terms of reporting on that? So if we look at, for example, the number of patients waiting more than 52 weeks for treatment, which currently stands at 408, would it be good to get a sense of how many of those are waiting, say, up to 2 years or more than 18 months? And so we can just see if that, that is an improving position. And as I say, apologies if I missed that in your in your sort of narrative. So particularly the ones, things like autism, where it's going up, is also just keep an eye on who are our very longest waiters. Some of those, there may be reasons, why that might be in terms of other things that are going on in their lives. But it would be good to get a sense about where that is really.
I'm happy to do that, and I have been doing that periodically, Dean, through the Quality Committee anyway, quite rightly, to provide assurance that we are focused on those. Can I assure you that in each service area we understand that position down to individual patient level, as you would expect us to, and actually a lot of those services where the clock doesn't stop till diagnoses, as I've discussed here before, that does not mean that we are not in contact clinically. In fact, we are with those service users and their families as well. And I think that really gives assurance that, and obviously, if for any reason amongst the group who are those longer waiters, that their needs escalate, then we have mechanisms through our waiting times procedure to escalate those through the waiting list too. We're really happy to provide an update around all of the work that we're doing to manage that well.
Thank you, Lynn. If there are no further contributions or questions, I suggest we receive and note that report and move on to the next item. Okay. And the next item is the finance report, and I'm going to suggest we take a little comfort break after that. Pete.
Thanks, Caroline. So hopefully we might get through the finance report quite quickly then with that incentive at the end. So this is the finance report as at the end of August. I think it's important I continue to remind the board that we are still operating under the block funding arrangement. Some of the key highlights from the report questions are, you'll note that at the end of August, we recorded a financial position consistent with our NHS planning target for H1. So that's a 245,000 surplus with a target of 315 by the end of September. Our COVID spending income up to the end of the month totaled 2.9 million. So that's a combination of expenditure on top of lost income. And you'll note the cash in the bank remains healthy at just shy of 24 million. As I sit here today, we are still waiting the planning guidance and allocations information for H2. I think that's a frustration across partners and other colleagues across the NHS. When that comes out, we will send something from the board of what H2 planning looks like. So I'll stop there, Caroline, and I'm happy to take any questions on the report.
Thanks, Pete. Any questions? Peter Barron.
Yeah, no, that's a really great report. Thanks, Pete. And I think that our finances are in a really great position. I've just got one thing really. If we go live with the provider collaborative from the 1st of October, how will you present the big numbers that are going through that part of the trust in the finance report? Will they be separate? Will it be a separate report, or will you just highlight it separately in the report? Have you thought about that?
It's a really good question, Peter. My intention, but I'd probably take this through EMT and Finance Committee, would be to report it separate, so we'd continue to report, at least for the remainder of this year, for continuity on the core provider operations of the trust, but we'd have an appendix within the finance report or a separate finance report on the finances of the provider collab.
Okay, Peter. Michelle.
Yeah, no, I think it needs to be separate. I think it's certainly, even if it's just part of year, Peter, till we get really well established, I would want to see a separate report.
Okay. Thanks for that. I can't see any other questions at this stage. So I'd suggest with the board's approval that we take a comfort break and come back. It's 11:12. Come back in, how long? 10 minutes? People need 10 minutes? Good. So 11:22. So James, if you could stop live streaming, please join us back at 11:22. Welcome back, everybody, to the Trust Board, and we're going to carry on with our agenda. And we're now going to go on to the area where we take our Assurance Committee reports, starting with Francis and the Finance and Investments Committee Assurance Report. Francis.
Thanks, Chair. I'll keep this very brief because actually Pete's update supersedes this because this is back in August. So the only things I would pull out of this really are the Humber Coast and Vale position of 13.1 surplus, but even that now is fairly out of date, and Pete might be able to update further. Good control of cash and some great work by the team on working with Hull Council to sort out some debt we had there. And we reviewed the BAF and risk register, and we can pick that up later again because it's on the agenda, because we did just question the level that it was at, but everything else there is for note. It's been superseded by Peter's report, so happy to take any questions.
Okay, thank you. Anything to add, Pete, or can we just see if there's any questions?
Nothing to add, Caroline. Happy to go to questions.
Lovely. Any questions? No? Right, therefore we can receive and note that report. Thank you, Francis. Moving on to Charitable Funds Committee Assurance Report, Peter.
Thanks, Caroline. Yeah, I'm temporarily the chair of charitable funds just for a couple of meetings, but we had a meeting last week, so I've just summarised it there. I wasn't going to go through it in a lot of detail, but just perhaps to let the board know that obviously last year we had the impact appeal relating to Inspire, which raised the kind of $250,000, which was a really great appeal, and the charity managers did a fantastic job on that. This year the main appeal relates to Whitby, and we've raised around about just over 30,000 out of a total that we're hoping to raise of 130. So it's a little bit slower. I guess perhaps that's the environment that we are living in. But there are a lot of actions behind the scenes to sort of work with partners to try and get that towards the figure that we're aiming for. So there's a lot more work going on than actually we've had the credit for in terms of the amount of money that's been raised this year so far. So I'm hoping that we'll see an improvement. But at the moment, it's slightly of concern that if you look at the ratio of charitable donations to costs, the ratio is 1.04, which is extremely low. But a couple of good donations relating to the Whitby appeal get that towards the 130 that we're aiming for, and that ratio should improve. And we're hoping to sort of reinvigorate some of the general charity work as well, such as the giving through payroll and things like that. So perhaps we're going to have a Health Stars month like we have all these other, the Black Minority months and the Freedom to Speak Up month, etc. So they're thinking about one or two things to try and reinvigorate things. Yeah, that's the report. Just go to questions.
Thank you, Peter. Mike.
Yes, thank you, Peter. I don't think the charity should beat itself up too much about the fundraising. It is a national issue, and certainly within other charities, the priority has been during this last year to actually spend money and to make sure that our staff are looked after. That's been the most important thing, to look after the well-being of staff, and the charity has done an excellent job still on its day-to-day business. The chief executive has her own fund, and money has been expended very wisely in my view, so I'm fairly relaxed. There's a job to be done, but I don't think that this charity is outside the norm in the NHS, and I think we've done the right thing.
Thanks, Mike, for giving some context to that as well about the last year and what priorities we've had to face. Anybody else? Okay. Thank you, Peter, for that report. We receive and note that. Moving on then to the Quality Committee Assurance Report, and back to you, Mike.
Yes, I'm interim chairing this after Mike Cook's retirement, and you'll see from the bullet points on the front that a lot of the work of the committee at this meeting was to do with receiving annual reports, and one of them came here. But I would highlight that that's not the substantive work of the committee, and you will note that the risk register item was interrogated, and we were looking at the early intervention team's improvement plan and the national pressures on CAMS. We also looked at the ligature report, which is extremely important, and we have an enormous programme of works that are taking place through our estates department. So I think it was, even though it was tilted towards the annual reports that come through, the Quality Assurance Committee is still working hard on maintaining patient safety.
And it's a very detailed report. Thank you for that. In fact, thanks to the committee. Any questions to Mike? No? Okay. Thanks very much, Mike. We receive and note your assurance report, and we move on to Dean for the Workforce and Organisational Development Committee assurance report.
And again, Chair, just there for information and for people to note it. Just a couple of things to point out. A fair bit of work has been done on pulling a workforce insights report together over the past few years. And what we've been doing is sort of culling that down. So we've got a more strategic focus on it, and then just going into deep dives in areas where we think it's appropriate to get a bit more information rather than get that at every meeting. So this was our first one, really, in terms of looking at absence. Really good report that we received there. Congratulations to the team that did that. That just enabled us to get down into the information. We'll look at other ones in the future, such as turnover, for example. And then you'll also see on the paper, it did come up in the performance report as well, that we just asked for a bit of a forward look, really, about the statutory and mandatory training and a sort of recovery plan. So there's a few areas where compliance isn't at the level that we'd want it to be, and we want to understand, is that lack of access to available training or staff not being able to get released, and how might we fix some of those sorts of problems. But happy to take any questions on that.
Thanks, Dean. Any questions to Dean? No, thanks for flagging that last point up as well, Dean, to let us know what's happening there. Thank you. That's received and noted by the board. And now we move back to Mike for the Mental Health Legislation Committee Assurance Report.
Thank you, Chair. If I could deal with this in two parts. First of all, the general work of the committee, and then the board approval issue. The first one is about the general work of the committee. We're very ably supported by the Mental Health Steering Group under the leadership of Kwame Fofe, and that's going very well. All of our indicators are within the tram lines. We're doing a lot of good work on reducing restrictive interventions, which is the acronym is RRI, and also de-escalation management and intervention. We're actually an outlier in that area, a positive outlier, that we have a lot less seclusion and interventions than you would expect to be the norm. I'm trying to get back to business as usual. I've asked about attending the patient council at the Humber Centre, and that's to be arranged, but I still want to make sure that I've got my head in the door in terms of the actual experience of patients. And we had a good look at closed cultures and transparency. And as part of that, I think I would highlight that it's not quite closed cultures, but we have the CQC in attendance, and we cross-reference their insights report against our own reporting. And it was really pleasing to get the CQC there, because we had some excellent input from them, and it was very clear that the people who are managing this data know why they're managing the data. They're not just number crunchers, they're actually interrogating that data usefully. So we've got a good contact, and I'm hoping that John Byrne will be able to keep up with that contact in terms of the CQC, and it does put us in a tremendous position, and that we have a relationship with the CQC. And I know other colleagues at executive level in particular have these relationships, but back to the closed culture, it just demonstrates an openness in this trust that I think these individuals, if I may say so, were pleased to come to an actual meeting and see what the impact was and what we did with their statistics. So that's the review of the meeting. Are there any questions on that to start with? Okay, well, I'll move on. I've made a few notes on this one because I want to make this into a fairly simple issue. The Mental Health Legislation Committee received a paper concerning a putative policy, a policy that was thought to exist, regarding hospital managers who exercise their discharge power on behalf of the Trust under Section 23(6), and whether a governor could be a hospital manager because of a perceived conflict of interest. So under its terms of reference, the Mental Health Leg Committee has the remit to approve and review mental health legislation policies and procedures. So that's what we did. The policy presented was first of all found not to have been through any governance process and was therefore the first time that Mental Health Ledge had seen that policy. So we therefore considered it afresh and just looked at it from an independent point of view against the legislation. And the legislation was very clear that under 23(6), the power of discharge may be exercised by any 3 or more persons authorised by the board, each of whom is neither an executive director of the board nor an employee of the trust. So the Mental Health Act's reference guide also confirms that hospital managers can be anyone as long as they're not execs or employees. Despite the existence and the purported currency of this, one of our hospital managers has also been a governor for the last 3 years and has sat on managers' panels. Similarly, the mental health chairman, who is me, is also a designated hospital manager, and I've also sat on panels. So it does seem difficult to sustain the fact that there could be a conflict of interest. And there's no precedent in other trusts for this happening. And indeed, the courts have recognised that there's no conflict between roles, for example, of a responsible clinician who sits as a tribunal judge looking at a previous patient of theirs. So in the light of the above, the Mental Health Legislation Committee saw no reason to approve or implement the putative policy and thought that governors should not be barred from being hospital managers. However, this is something that we've looked at in detail with Mental Health Legislation Committee, but hospital managers' discharge power is an approval of the board. So I come to the board to say, well, this policy did supposedly exist. I don't know why it was there. I don't think it should be there. And I don't think there's any impediment for governors to be hospital managers. So I request board approval.
Thanks, Mike. Any questions or comments? Okay. In that case, we receive and note the report, and that obviously contains the recommendation in that regarding hospital managers, Mike.
Thanks very much.
Thank you. Okay, moving on, we move on to the Audit Committee Assurance Report. Peter.
Okay, thanks, Caroline. We had a really good Audit Committee in August. I've done a reasonably detailed assurance report there, so I'm not going to go through it in a lot of detail, but just to pick out maybe three areas. First of all, internal audit, we had 6 reports in the period. And we don't choose areas that are going to be easy to audit and where we're expecting necessarily high assurance all the time. And so clinical governance has perhaps been one of those areas. But what I would say, with it being limited, we did learn from that. And there's been a subsequent clinical governance audit, which has had a much higher rating. And also that report, which was limited assurance, was discussed at Quality Committee. And all the actions, all the significant actions from that have been implemented. So that's the purpose of these reports, is that we find areas that need actions and we do something about it. So and that's an area that demonstrates that happening. The other areas, I mean, if you wanted high assurance from a couple of areas, broad assurance framework and performance reporting and management is 2 that you would choose to get high assurance from. So really well done to the teams for getting the top marks, if you like, for those. Other areas to highlight, perhaps on costs, insurances, and particularly clinical negligence. That's just the world that we live in. It's claims related to some extent, but you'll see it's gone up from 494,000 to 634,000. So that's 140,000 increase on our costs. I know that Pete's the budget's accordingly for that, but just to note that really. And we also in the meeting received the annual report from the information governance team, which was very well received, and I did circulate it. It's not come to board, but it's one that I thought board members should see, so I did circulate it to board members so that they could read it at their leisure by email afterwards. And it did give us really good assurance that this important area of information governance is being really well managed by the Trust's employees. But we also discussed things like the number of subject access requests that come in through that, because this, a couple of years ago, new legislation came in which meant that subject access requests could be made by members of the staff, members of the public, etc., at no cost to them, as long as it was reasonable. And the numbers of requests has increased an awful lot. I think we had nearly 700 requests in the last financial year, and that's valid requests, I'm sure, but the cost to the trust is probably over one clinician, but between 1 and 2 clinicians to actually handle that volume of requests for information. So just to put it into context, that there is quite a significant cost to that work, but it's all been handled properly. I did circulate the report outside of the meeting so that members could actually have a read of that really excellent report. And that's it. Thank you. Unless there's any questions.
Any questions? No, thank you, Peter, for that comprehensive report back and for circulating the other document you mentioned. Thank you for that. You're on again, Peter. Commissioning Committee Assurance Report.
This is an easy one because, we did have a meeting as we've got there on the 24th of August. Obviously, we go through the finances and we go through quality. Pete is there and Dr. David Harvey is there as well, and we go through that. So I think what I'm going to do is say that you've had a more recent update at the board timeout last week, covering both finance and quality. So I don't think there's too much point me really labouring that too much. But what I would say is it's been very well controlled and teams working really well, and I'm really confident that it's an area as regards the shadowing of what NHS done. It's really top class. So I've been impressed with the way the team has gone about its business. In terms of that particular meeting, we weren't quite quorate. Hanif has now come on board. I don't think he's perhaps there, but we have now got 2 non-executive directors on that committee. I think the terms of reference perhaps just need to be slightly tweaked to reflect that, because at the moment I think it's just got 1. But apart from that, I think there's nothing else to say. Have I covered that, Michelle?
Michelle H, yes, thank you for raising terms of reference. So board approval to update that in the absence of it being done in commissioning committee. Thank you.
Yeah, thank you.
Thanks, Peter. No questions, so I think we can receive and note that report. Thank you, Peter. Now we move on to item 19 on the agenda, because we took item 18 earlier, a quality improvement strategy. John.
So thank you, Chair. The strategy has been through ODG, EMT, and it's also been to the latest Quality Committee and has a good working over. Essentially, this is our second quality improvement strategy. We developed our first one approximately 3 years ago following a CQC report where it was just acknowledged we didn't have a strategy in place, policies or procedures. So what we've done, led by Catherine Hunter over the last 9 months, is just led a review of our strategy and a refresh. Just before your time, Chair, we did start the conversation off at a board development day. I think it was about 9 months ago, when the board considered it and thought actually more of the same and the steady as we go approach was what we were going to do, as opposed to perhaps transacting into a bigger programme. The one thing I would say is, as I think as the ICS develops over a period of time, as we see new providers and frameworks developing, we may need to go around that buoy again. But our current process, based on sort of the model for improvement and empowering staff and patients to work together, supported by a small but bespoke team, is probably what we need to do over the next 18 months while the rest of the system sorts itself out. In the report, we've highlighted the successes against the previous strategy, a simple plan on the page. And for those of you who joined any of the quality improvement sort of webinars we've done over the past year, I'm sure you would have seen that some of that progress. The interesting, we were slightly ahead of the game in some ways, that if you want to train in quality improvement training and go through the NHS framework, dare I say it's very laborious, can be anything from 3 to 5 days. And we took that decision just to truncate the training, make it into bite size and more appealing for people to join in. Because you don't need to necessarily be a rocket scientist to do quality improvement. You just need to have the interest and some of the basic skills. So we tailored that national learning to meet our own needs. we found that actually very successful, and funny enough, the national programme is now changing its approach and truncating the amount of time people need to spend to get the various awards. So I'm happy to take any questions on it. I'm not sure if the Sway link is working this morning, so that's our outward-facing report, which we're updating so people outside the organisation can see some of the stuff we're doing. We've kept the report short, but we've stuck the appendices in because there's lots of people who always like a bit more detail. So that's why a sort of 10-page report has a load of appendices, because people just want to know what else has been done.
Thanks very much, John, for that. Any questions to John or comments? No. Thanks very much, and a very readable report, I would say as well. I like the diagrams and things. It's very helpful to guide you through it all. Thank you for that. So we receive and approve that report. Everybody happy? Brilliant. Great. And now we move on to item 20, clinical review of issues arising from the transfer of community paediatric medical services of City Healthcare Partnership to Hull University Teaching Hospitals. And we've got Trish joining us, I think, as well. Lynn, are you introducing Trish, or is Trish going straight for it?
I can go straight for it, Lynn, if that's okay. Hi, Caroline.
Hi,
Trish.
Welcome.
Welcome to the Trust. Yeah.
Sorry,
Do you want me to
just keeping you waiting?
No, that's fine. I had plenty to do.
I'm sure.
It was fine.
Over to you.
Okay, so shall I just basically run through the report and then take any queries? I'm sure people have had a read. I guess the biggest shock really is that the report is actually nearly a year old, and there's just been a flurry of activity that Hilary and I got involved in about 2 weeks ago, Hilary, with a quick distribution of the report. So the potted history is that City Healthcare Partnership started to hold discussions in 2018 on the transfer of their community paediatricians to Huff. City Healthcare Partnership were very transparent, but they were really struggling to recruit doctors and were failing in their statutory duties in the care of children and young people, particularly children with long-term health conditions. And there was also a significant lack of clarity on the support that was required for children with neurodiverse conditions like learning disability, autism and ADHD. So that led discussions beginning to happen with Humber Trust in terms of how we could support the transfer of those children into a more appropriate pathway. So the discussions actually started in 2018 around the changing of pathways for neurodiverse children and young people to meet the NICE guidance that was emerging. And in terms of children with longer term conditions for Humber Trust, that also included children and young people with cerebral palsy, as we actually have paediatric therapy services within our portfolio. So the concerns that were beginning to emerge really that the diagnosis, particularly for Humber and the youngsters with ADHD, the diagnosis was not always robust, it wasn't trusted, and we were beginning to have some concerns in respect to possibility of overdiagnosis and underdiagnosing of some of those children. So from June 2018, Humber opened up the door to take new referrals in terms of ADHD, autism and learning disability into the CAMHS services. In February 2019, we saw the formal notice served by CHCP and the willingness of Humber to take on the legacy cases of the children that were still kind of within the system. As the report alludes, there were actually 2,427 children and young people that were transferred over into the paediatricians into Huff. But obviously there was a lead-in time because Huff had to recruit paediatricians, and to be fair, Humber had to make a recruitment of a CAMHS locum consultant for us to be able to facilitate the support of the transfer of those children. I can say that all of the children, all 2,427, were desktop reviewed by paediatricians, and paediatricians literally worked through weekends and evenings to get a desktop analysis done immediately. All of the children were given a plan, and families were contacted, and the children that began then to transfer over to Humber Trust, we sent letters out to each and every one of the families to explain how the service would be delivered differently. We also risk stratified the children that were coming over. We absolutely made sure that we only took the children who had no underlying physical health problems, because the ADHD medication that's prescribed for children actually can have an impact on cardiac issues. So we screened out any child that had any cardiac issues, and they remained supported by the paediatrician. But in some instances, we also began some joint clinics. We employed the locum CAMHS consultant. We still have that CAMHS locum consultant. It's not the same one, but we still have that post. We have secured funding for longer term to ensure that the children that were transferred are monitored, and any new referrals are seen in a completely different way. As the report alludes, there were 11 children identified as suffering potential harm. All of those individual families have been contacted separately and supported. The harm included undiagnosed conditions and also late appointments and limited reviewing, but no serious harm for those 11 children. But there was an SI of one particular child where there was delayed in a significant delay in treatment. So I guess what we were interested in and what we wanted to ensure that we got involved in was the learning. There was certainly, going back to 2018, a recognition that the front door for children with neurodiverse conditions, ADHD, learning disability and autism, there were too many doors that those youngsters were going through, so their care was fragmented. We are very much part of the RCS development of a new front door for neurodiversity, and I'm sure I'll come back to the board to talk about that new front door at some point. That new service, it will be officially launched in December of this year. And we've also extended the new front door to include sensory profiling, sensory assessments within that. And the paediatric therapy services, with the occupational therapists and the physiotherapists within our trust, have all been very much involved in the development of a new cerebral palsy pathway, which has had some impact for paediatric therapists, because their work has generally been to see children, to have an intervention and to discharge. But all children with cerebral palsy now will remain on caseloads until they reach adulthood and transfer into adult services, because of the monitoring under the NICE guidance that's now recommended for anybody with cerebral palsy. So that's the nutshell, but I'm sure there are other questions that people want to raise.
Thanks, Trish, and I just wanted to mention, in terms of the report, that the independent chair did actually mention in his introduction that he was impressed by the honesty and candour of all involved and the firm commitment to find out what happened. And I think, you know, whilst not taking away anything in terms of the problems that happen for individuals and families that shouldn't have done, the work that's been done, which you've given voice to today, I think he says in his report, bodes well for the future. So that is to be, I think, you know, recognised and acknowledged as well in all of this. So thanks, Trish. Any questions to Trish or points people would like to make? I've got Francis. I've got Peter.
Do you want me to go first? Yeah, thanks, Trish, for that summary. And it's really important that we highlight these issues and learn from them. And it's good to see that the action list there, and that's, you know, something that we've taken on board with other trusts as well. So, but just a more general point, because you know, I'm sorry to labour this, but some of the harm caused was by using multiple locum medics, if you like. And I know in this particular instance, we then we managed to recruit substantive posts, but just in terms of the impact or the implication where we've got other locums in the trust, that's one of the reasons why, you know, I think boards should have some sort of oversight of where we've got locums, where we've got substantive posts, etc., on medics, because I think it does raise questions, possibly, on quality of care and things like this, where patients are seen by multiple practitioners rather than constantly seeing the same consultant or GP. So I think, you know, that for me is partly why I asked the questions earlier in terms of the oversight for the board on those vacancies and how those vacancies are filled. So I think that is an important learning I think
I think it's very true. The quality, you can't guarantee the quality of the locums that we recruit. What I can give assurances to that within the CAM services, within the community services, we are very dependent upon locum consultant psychiatrists, but we do have quite robust quality checks in place, and we have identified failings of a couple of locums, but we've terminated their contracts within hours and days. Really, we are I'm crossing toes and fingers here, but we're very fortunate at the moment that we've actually recruited a locum who's got specific interests and significant learning in neurodiverse conditions. It's sad that they will not take on a substantive post. We do offer that very, very regularly in the hope that we might entice those locums to come into substantive posts, but they seem to have all their own personal reasons for not wanting to do that. But we have sifted through a few, and you know, I am quite confident that we've got really good quality locum support at the moment.
Thank you, Trish. Francis.
Thanks, Chair. And thanks, Trish. Really good summation of everything. And to pick up on Caroline's point, I think the other thing that the Chair said, which was really important, was that it was a whole system. It was good to see the whole system working together to put this right. Just a high-level question. Obviously, from what I gather, you're happy that everything has been dealt with in terms of all of the recommendations, and we've got the learning from it. Has that learning been spread? Because obviously there's learnings from this that could go into other parts of the trust in terms of other services. Just so we can pick up on that, has that been spread around, or is that at the moment has it stayed within your area?
It has gone across wider services because it's involved some of the transition of the young people. So we picked up quite a lot of 17-and-a-half-year-olds. So we needed to make our adult colleagues aware of the difficulties that some of these young people and their families had experienced at the time. I think the sadness was that not a lot of the families had a great awareness that things were not going well because it's what they'd been offered, it's what they accepted. So I think we've had some really positive feedback about the different aspects of the support that we offer. There were challenges because some of the youngsters who were diagnosed as having ADHD were seen by our psychiatrists who said they definitely didn't have ADHD. They had other issues and other conditions, but that meant stopping medication for some families. So, you know, there were some challenges, but we did deal with them as individuals along the way.
Yeah. And I'll bring in John, and John's made the point. This harm was caused on another provider's situation, and we had to basically try and sort this massive problem out, as far as I'm aware. John.
Absolutely.
Sorry, Trish.
Yeah, thank you, Chair. Just to reiterate that point, that actually this is a fascinating report. It's really important. It does show what happens when a provider not fails, but struggles to provide a complex service which is related to workforce. And actually, Peter, perhaps that's something to think in terms of the Provider Collaborative Committee, because I think the biggest risk across the NHS is now accepted to be workforce. And actually, this highlights something that happened sort of 3 or 4 years ago. And despite scrutiny and a review from the CQC rating the service as good, there was clearly underlying problems, which we, and particularly HUT, have had to pick up since that service was terminated. Your point about locums is well made, Peter, that in terms of continuity and increasing risks, that's well established across the medical networks. But what I would have to say is through the clinical governance networks that we have set up in the Trust, which are jointly overseen by Hilary and myself, we are a high reporting trust in terms of picking up incidents. And as Trish alluded to, when we pick up issues with clinicians, be they doctors, nurses, AHPs or anybody else, because of our ability most of the time, you'd be hopeful of picking up the problems, we can act quickly. So actually, when it comes to locums or agency people, irrespective of the background, we can move them on very quickly, but where appropriate also report them to the GMC or the NMC as required. So all of those systems have been in place in this trust for quite a while, and they work well. I would never say everything is watertight, because you know that from an audit perspective, Peter, that can never be the case. But I certainly like to think that it's something we endeavour to be on top of, because we do understand that there are risks pertaining with a workforce which comes and goes, irrespective of their clinical background, and indeed the same would apply in corporate services. And it's something we just have to manage and watch very closely. The ambition would always be to have a substantive workforce. Why wouldn't you want that? For quality reasons, for cost reasons. But when we look across the broader NHS and the vacancy rate, actually we are, like many other 220 NHS providers, fishing in the same pool, whether it's GPs, whether it's consultants, whether it's nurses. But I'm confident that we have the governance procedures in place, which would mean if we had problems like this in the service, and we have, and we know we talked about things that have gone wrong in our trust quite openly at board, that we would have those processes in place. But I would just be careful about linking your wider point about locums to this particular report, because I think there is something about how commissioners oversee the services that they commission, and that might be some learning for us as we move forward with the provider collaborative.
Thank you, John. Michelle.
Yeah, I mean, I took my hand down, because I think a lot of what I was going to say has been really said, really, and reiterated by yourself, really, that this is obviously a report, and it's about how we actually helped and enabled the system. We are taking a bit of this into the collaborative when we sort of look at the provider collaborative work from an ICS, as we look at quality and what have you. I think there are some obviously some lessons that we need to think about in relationship to agents there. I think John's alluded to those, but I do think, as we raised earlier, I think we do continually need to be astute in relationship to, we are still employing a lot of agencies. Yes, we've got a lot of governance processes in place, but we need to triangulate that in relationship to the reports, which I think we touched on earlier on in the board. And I think that's really important, that the board have that assurance. It's not just about finance and quality, but the two come together. And then sort of finally, I was going to really thank Trish, because I know that when this happened, it was a huge amount of work to do in a relatively short period of time. And I think the way that the team managed it with empathy and support, not just to the staff, but to the service users and the families as well, was just amazing at the time. I know we said that then, Trish, but it was a huge undertaking in relationship to the figures. So I just wanted to say well done. And yes, we can all learn from this report, but well done to the team for that.
Thank you, Michelle. And the only other hand I've got up before we go back to Trish and say thank you to her is Lynn.
Yes, thank you, Chair. I'm very sorry. I was disconnected inadvertently by MS Teams just as this item was introduced. A lot of what, so I won't repeat it, but I think the point's been made. This was an interesting investigation. It was a systemic review of a system issue. And I think it's quite fair to say as well that we've learnt as a system, not just about this particular case, but some points for the future about this type of review as well. So I just didn't want that to get lost either. And I think, connected to John's point, I won't reiterate it, around learning for us here around locums. I would also add that we have now got a clinical director as well. A big part of Kwame's role is that oversight around clinical quality, clinical governance, and he supports all the divisions in relation to those medical aspects, particularly where locum issues arise. So just to add to that in terms of assurance. But Michelle's made my other point, which was really around reflecting on the amount of really positive in-depth work that the team undertook in managing the obviously the transfer of this number of cases. Particularly, I think Trish has touched on it, the amount of contact communication that was needed with families around this, because it was very intensive. So again, I'd just like to recognise the work that the team undertook there. Thank you.
Thanks, Lynn. Trish, last word from you, and thanks for your contribution today, because I think you explained it really clearly and it was really helpful. And I think the point you made, and it's just been iterated by Lynn, that families didn't know they weren't getting the service that their kids deserved. I think that's something for all of us to always be mindful of. Trish.
No, thank you all for your feedback. I'll make sure that it's shared with the teams.
Thank you. Thanks, Trish.
Okay. Bye.
Bye. Have a great day.
Okay,
right
cheers
now. Thank you. We move on now to item 21, Infection Prevention and Control Strategy Refresh. And I think we have Debbie Davis, Lead Nurse Infection Prevention Control, with us. Debbie, are you there? Yes, she is. Welcome,
Hello
Debbie.
there.
Thanks for being patient. Can we go straight to Debbie, or do we need to go to you as well, Hilary?
No, hand straight over to Debbie. I don't want to steal any thunder.
Debbie,
No,
you're on.
that's okay. Very short and sweet. The first one. You know, kind of our infection prevention and control strategy was developed in 2018 originally. And the goals were aligned to the Trust 5-year plan. Whilst a large proportion of our goals have actually been achieved over the years, disappointing to note over the last year with our promotional activities have actually stopped due to the kind of the effects of the pandemic. And what we're hoping, kind of to gain support for was for, kind of for an extension of the original strategy with a few minor tweaks for the next year.
Brilliant. Okay. Did any questions to Debbie on that?
So it's just one just to say, don't be too disappointed, Debbie. It has been an exceptional year, so please don't be disappointed. I mean, I will say this next. I said the amount of work that the team have done has been phenomenal. So please don't feel it's a criticism, because it's absolutely not.
No, I mean you've all had to deal with extraordinary circumstances, in all of this, and so yeah. Shall we? If we see that, are we going to go on to the annual report, Debbie? Because you're doing that as well, aren't you, for us? So let's hear that, and then we'll see if anybody's got any other questions to ask. Thanks, Debbie.
Yeah, that's fine. Kind of the front sheet highlights some of the key achievements against our strategic goals, but also against our locally agreed performance indicators, which, despite all the challenges, we've still managed to achieve, and we've attained or exceeded what was asked of us. I would also, however, like to make specific reference to pages 11 and 12 within the document, which provides a brief summary of the outbreaks identified during this period within our inpatient settings. While on the face of it, reporting 14 outbreaks does not appear to be much of an achievement, I do believe it is to the testament of the kind of the clinical teams and the organisation that the measures that were put in place, kind of minimise the harm to both patients and staff in the majority of the instances of the outbreak. Kind of the national data suggests that transmission rates of 38 to 40%, kind of have occurred in quite a lot of the mental health settings, and as can be seen from the, kind of the data produced in those reports, the transmission rates to the patients was really, in the majority of instances, was kept down to a minimum. I think the kind of the main measures, kind of that I think really made a difference was the kind of the COVID, the setting up of the COVID designated areas, which reduced the transmission, kind of potential transmission to others, and kind of for those patients who weren't already incubating. And I also think that the the COVID response team in the first instances, kind of made a significant difference in the kind of the staff's competency levels when they were fearful, particularly in those first instances of dealing with patients with clinical, kind of with the clinical symptoms that they were exhibiting. Other things I think that has been a real achievement. I think the work that has been done on the donning and doffing facilities and the improvement of facilities, which has caused really a massive amount of challenge, particularly within our settings with the challenging patients that we have and the amount of space and, the environmental constraints, i.e., en suites, etc. And lastly, I think there's a credit to the clinical staff who have been extremely engaged in all of this. We've been engaging with staff we've never spoke to before. Kind of through the organisation, I have to say, I didn't even know some of the smaller teams did actually exist. But the clinical staff have been creative in trying to create solutions, particularly in the use of PPE, with the PPE in a pocket, which which there's a finalist in the nursing times, and hopefully we'll go to a good night and a win. But yeah, there's been, so although it doesn't look like an achievement and there are some lessons to learn, I think it should be treated as such. I'm happy to take any comments, thoughts about the report.
Thanks, Debbie. Anybody got any comments they'd like to make, Peter?
Yeah, thanks, Debbie. It's amazing with such a small team. You do so much work, and you've kept on top of this really so well, despite all the conditions that we all had to endure in the last 18 months. So really well done. I've just got a quick question about patients, and obviously the safety of patients is paramount. But in terms of their health and well-being, I guess that they want contact with their loved ones, with their families, and with their friends, etc. And visiting patients in hospitals and in inpatient wards especially has been very difficult. So perhaps you could summarise where we're up to with visiting and what we've done proactively to help patients have conversations with their loved ones whilst being in a more restricted environment by use of technology, and how we've helped in that.
We haven't. We've obviously discouraged visiting in some instances where it was, where it would potentially be detrimental. However, visiting has not stopped throughout the pandemic period. We've made provision for, for individuals who are extremely struggling, particularly in the, in the scenario of Maester Lodge, when, yes, theoretically, we've got a lot of patients who are end of life due to the dementia. We've made additional provision. We've taught the ward, particularly, have taught staff, taught visitors how to put PPE on appropriately. We've I don't say encouraged, but we've allowed visiting to go ahead, but it's all been done on an individual risk assessment basis. And if there's some health and wellbeing issues, which I can come up with a creative solution. That might have been in the pod outside. It might have been with with the use of an iPad, but certainly we are encouraging visitors for those who are are going to suffer due to the mental health it needs.
Thank you, Debbie. Hilary?
I just really wanted to say thank you to Debbie and the team, but everybody else that's been involved in infection control over the last 18 months. It's been an absolutely massive effort switching to working in a pandemic, and I think that the estates team have been fantastic working with Debbie and the team, health and safety. We've had excellent support from a consultant microbiologist who seems to attend all of the meetings that we ask him and has been fantastic in advising us. We've had to really shift the thinking around infection control. We put in very early, we put in additional capacity into the infection control team on a substantive basis because we could see where things were going. And the things that Debbie and her team have had to deal with would never have been expected of some infection control teams. And I just thank Debbie and the team for being so flexible and getting the achievements and keeping staff and patients safe throughout all this pandemic that we've had to deal with.
Thanks, Debbie. Thanks, Debbie, so much. And John's put in our chat box that after wave 1, we only had 10% positivity rate after testing was carried out across the trust. And also, it also helped in terms of colleague sickness as well. So I think you've done a tremendous job, and everybody involved in this across all the different parts of the trust. And I'm sure there's a lot of learning to take forward, which is going to be really helpful in the future. So thank you, and thank everyone you work with.
Thank you. It's been a massive team effort, I have to say.
Brilliant. Thank you. Okay, brilliant. Now, moving on, if we've received and approved the annual report, with everyone supporting that, we go to the Board Assurance Framework, and we've got Oliver Sims, who's our Corporate Risk and Compliance Manager, who's going to, I think, introduce this. Michelle, did you want to say anything before Oliver comes on?
No, just obviously it's there. Oliver will go through it. We have asked each of the directors to do a comprehensive deep dive for their particular area. Some of the changes have been enacted. Some of it is still a little bit of a work in progress, but I'll let Oliver take you through it. Morning, Oliver.
Hi, Oliver.
Good afternoon, everybody. Okay, so I'll just make reference to obviously the document and some of the key points, and then happy to take any questions at the end, and then we'll be doing the risk register item as well, I think, next. In terms of the Board Assurance Framework, so this document will represent the final position for Q2. Against all of the strategic goals, we haven't seen a lot of change in terms of the individual ratings, but that's typically what we'd expect to see going from Q1 to Q2. There has been quite some significant work in terms of the individual risk registers that underpin this document within each of the divisions. and across obviously the corporate teams as well. So we'll likely see some further sort of changes that may have some significant impact in terms of the ratings for Q3. But as it currently stands, and as Michelle has alluded to, we're going to be doing a bit of a deep dive going into next quarter as well. The document, as ever, has been through the board subcommittees that are aligned to the relevant strategic goals. So obviously we've worked on any feedback or any comments that we've had via those meetings, and essentially, as I said, it represents that final version for the quarter to obviously give the assurance to the board against the risks aligned to our individual strategic goals, as I said, for Q2. So I won't go any further detail. If there's any questions or any comments, happy to take those now.
Thanks, Oliver. Any questions, comments? Francis? Francis, you're on mute.
Knew it would happen at some stage. Thanks, Oliver. Really comprehensive as ever. A couple of points that I just wanted to pick up on. One's an overarching comment, which is that we've had actually no movement on any of the objectives, and it's just a point that I know Michelle made a couple of meetings ago in one of the subcommittees. So all of them seem pretty flat. So it's not for answering. It's just something that we need to think about because it's not changed. Second point was on the first strategic goal of innovating quality and patient safety. I just wondered whether the nurses and consultants issue should also sit here, because it's not only a workforce issue, it's also a patient safety issue. So I just wondered if they should sit in that particular box. I'll give you a couple of other ones and then pass it over to you to pick up on. Let me just move through it. The third thing is that there are a number of things in there in terms of actions which are due up now, so to speak. So not for this meeting, it would be for the next meeting to have an update as to what impact those had, because obviously it plays back to my point about movement from quarter to quarter. So those are the key ones, Oliver.
Thanks, Francis. Oliver, back to you.
Thank you. Yeah, I think that's a fair point regarding the workforce risks and look at the impact. Obviously, we'll pick that up as part of the deep dive work for Q3, and obviously revisit each of the sections with the relevant exec leads. In regard to the actions, I think obviously that's been a bit of an ongoing theme. We've had some actions that have gone up to the end of making sure the updates are included. So again, what we're trying to do, obviously, when we do the reviews now, is make sure we're looking ahead and being very realistic with the actions and making sure that obviously we're looking at the outcomes of that and making sure that they're aligned as well. I think there is a deep dive report coming to the next audit committee in November, which is going to be looking at sort of the impact that the aligned sort of risks and actions that have been taken throughout the year have had. So we'll continue to do that work, but I think obviously it's a key point and it will be as part of that Q3 review. So thank you for raising those parts. Thank you.
Thank you, Oliver. I don't see anybody else with their hands up, so if we could move on to the risk register, please, Oliver.
Certainly. So the Trustwide risk register document represents the highest rated risks that we currently have identified within the organisation across both the corporate services risk registers as well as the risk registers for the individual clinical divisions. In terms of the current composition of the risk register, there's currently 11 risks that have been identified with a score of 15 or above, so our red rated risks that are reviewed on a monthly basis by EMT and the operational delivery group. Obviously, there's underpinning processes that sit alongside that in regards to the individual divisions and corporate teams as well. The key changes to note are the addition of some new entries from the last version that came to Trust Board for Q1. In terms of the workforce entries, obviously those are carried over in regards to the vacancies and retention for specific hard to recruit staffing groups. So that's WF 03, 04, 10 and 25. So those ones have carried over but still represent quite significant risk for the Trust. The longer term financial sustainability risk has obviously been fully reviewed and again does remain on the risk register as we currently stand. And then there's two risks in regards to the Ops Director, Ops 11, Ops 13 that have carried over as well. The four new entries are risks that have been escalated from the clinical divisions. They've gone through the operational delivery group for review as well as gone to executive management team. And it was felt obviously those risks are at a level now that need to be escalated and included on the Trustwide register. So obviously they continue to be managed and reviewed locally by the relevant divisions and the teams that obviously underpin those risks, and will ensure that obviously it's as live as it possibly can be in terms of as the situation changes, it's reflected on the register. But as it currently stands, obviously those risks do present quite a significant challenge to us as an organisation, and I'm sure some of the elements have been brought up in some of the performance reports and data that you've seen earlier today. So obviously those have been included and gone through our process. So we're just trying to make sure that the risk register is as live as it possibly can be. It's reflective of risk across the organisation, and obviously we continue to do that monthly process of review. So again, rather than go into individual entries, happy to take any questions or any queries on anything that's included on the report.
Okay, anybody got any questions or queries? No. Oh, sorry, John.
Just a quick one, Oliver. Is there any benefit in having a link to the NHS England risk register, so we can sort of perhaps look out at what some of the risks are in NHS England, just so we can look at our own risk register at the same time, actually go, yeah, we've got the same risks as the rest of the system, or perhaps we've got a slightly different risk to the rest of the system? Because I suspected risk of a pandemic wasn't on the NHS England risk register 18 months ago, but perhaps just no harm every now and again, not every time, just to sort of look out and triangulate our risks against them. I suspect they'll be the same ones, staffing.
Yeah, certainly. I think that would be a valuable exercise, John. I think obviously following comments from EMT's review earlier in the month, I think the plan is to maybe undertake that on an annual basis now to make sure we're kind of following in line with, obviously making sure that we've got everything we need to have on the document as well and on the register. So it's definitely something we're going to consider and pick up and factor into our work plan. And we'll make sure, obviously, as I said, we'll have at least an annual review of the national picture just for some benchmarking, and obviously we can see how we sit alongside those risks as well.
Thank you. Michelle?
Yeah, when we discussed it, because we did agree that we do that, we also said that I think what's more important is as the ICS develops to look at the ICS risk register, which partly we'll probably end up contributing to, but I think that's probably important. We said we do the NHSE one annually, but I think we need to do the Humber Coast Development more often, but we can see how that develops, but we agreed that.
Great. Thanks very much. Thank you, Oliver.
Thank you very much.
Thanks very much. Next, we have Dr. Mo Kadri, who I think is quite new in post, who's going to introduce the Guardian Safe Working Annual Report. Welcome.
Hi there, everybody.
Hi.
Hi, so I did provide this report, namely just to highlight the main issues. I think on the whole, there's been a dramatic improvement in the way that this has been approached. I suppose my job is to make sure that safer working for doctors is adhered to and managed. So that in summary, there's three main aspects to this. Is the structural changes. So that's looking at the rota, the work schedule, the cover of the junior doctors in what geography, which sections they cover, as well as recruitment. Second part has been the introduction of technology such as online prescribing, use of smartphone technology, as well as obviously video conferencing, which has reduced traveling time between sites and helps contribute towards doctors getting appropriate rest on call, as well as use of messaging apps and peer support within the junior doctors, which then provides them with an opportunity to manage difficult situations on call, emergency situations, without having to deal and cut into their breaks. So that's been really kind of a new innovation, and that's been taken on by the doctors, and it's had an improvement in the way they can take rest on calls, especially on long and busy shifts. And the third space has been training and education. So we've got a really robust program on a Wednesday morning for the junior doctors. They attend with the senior doctors, and there's a schedule regularly where we explore cases and explore how on-calls could be managed and scenarios could be explored. So there's this kind of real sharing of experience. There's also groups that run reflectively for junior doctors to explore in a safe space how they could have managed situations differently without concern about blame culture or concerns about getting into difficulty if they disclose things that in terms of their training and development. So they've got really protected spaces for that, as well as junior doctor committee where we discuss and explore any issues that come up, such as long working hours or if there's any change in the road. So these things get picked up very early on in the scheme of things, so then we can resolve them much quicker. So we're not waiting for things to get worse before responding to them. So there's this structural element, looking at the work schedule, the use of technology, and the third space is developing training and education in a reflective space for the junior doctors. And we're also looking at the rest room space, and I'm working closely with the junior doctors in resolving that as soon as possible. So we have got a site available. We're just in the middle of getting estates to kind of revamp that area, but it is a priority for us to work on. So that's a quick summary of the work that we've been doing in terms of providing safer working environments for junior doctors in training.
Thanks very much, Dr. Kadri. On the rest space you were talking about just then with this date, is there a timeline you've got for trying to resolve that? Is there a sort of sense of what pace that could be delivered at?
So I think the immediate plan shouldn't take very long. So we're hoping to get that resolved very quickly. It's not a big piece of work. It's just an agreement between ourselves and within the estates department. So I'm not expecting that to be very long. And hopefully I want to get that in place before winter comes in. And obviously doctors are going to be working across different sites in the winter. So hopefully well before then.
Thank you. Pete.
Thanks, Caroline. It was just on that point, actually, just to give a level of assurance. I know Dr. Quagger is working with my estates team, and we were looking at alternative proposals originally because we have got resource set aside for junior doctor accommodation, but we've now got a preferred outcome of a forward, which is, I have to use my language carefully, it's about making good some accommodation we've got in Miranda House the best we can, recognising that accommodation has got some physical constraints linked to it. So great that you're linking in with my estates team, Dr. Quadri, and just to give you an assurance that if it isn't moving as quick as you want, don't hesitate to get in touch with me.
That's great. Thank you.
Thank you. John.
Thank you. So firstly, Mo, thank you very much for joining us this morning. Mo actually is independent chair in terms of his function here, so I'll just bring the name of the paper. Just to say that in the short term, actually, if we look after all of our colleagues, be they medical or nursing, actually they are more likely to sort of perform highly and make less mistakes. So there's a real safety piece around getting it right for particularly junior doctors who I have to say work slightly different shift patterns and can have longer hours, particularly in the overnight period. So that's really important. The longer term is, if we get this right, we recruit people. And Mo is living evidence that if we get your training right and you get your welfare right, people want to come and join you in the trust. And that's where we've been successful over the last year or so, with a huge cohort of our trainees coming in, building on our reputation. And that's based on, dare I say, 3 or 4 years of hard work led by Stella and Gillian and Dugma and others, making sure we got it right with regard to juniors. And that's where we're starting to see it pay off. So just to pick up Peter's earlier point about risks with regard to locum and agency use and safety, I think we worked out 4 years ago in the trust that if we got the junior pipeline right, we'd start to see the benefits of it. And that's absolutely paying off. But that's not a quick fix. That has taken 3 to 4 years' work. We have a much better reputation now with Health Education England. And I think there's also a fairer share now of junior doctors coming into trusts such as ourselves who historically lost out to the wider region. So whereas we would have had to use an awful lot of locums to fill junior doctor gaps 2 to 3 years ago in the rota, fortunately, that's not the case. Now, the only challenge I would just point out is that the medical workforce is changing. We have more flexible working, less than full-time trainees, we call them, which does cause challenges for people who are trying to manage the rotas. But we're certainly in a stronger position now than we were even 2 or 3 years ago because of that work. So I just want to thank Jennifer Coonley, who was the Guardian of Safe Working last year, who's left the trust, and I'm grateful for Mo for stepping in. I think the juniors are in safe hands and they have an independent advocate there, which is the key piece.
Good. Michelle?
Yeah, thank you, Mel. Thank you for taking on this really important role. As you know, I meet quite regularly with the junior doctors, and it's good to see a couple of the recommendations about training and teaching for on-call, because one of the things that they do say to me regularly is that handovers from on-call you just need to be a lot more detailed, because sometimes I think that they don't feel confident in handing over some of their on-call to more of our established staff. So it's really great to see some of that in here. But just to say thank you for what you're doing, and also thank you to the junior doctors, because they do a really important job as well. But I do think we just need to keep picking up that scenario, that working relationship to on-call, and how our staff, our current staff, communicate with the junior doctors as well. I don't know if you probably picked that up as well, Mo. So I just think we probably need to pick that up. But thank you.
Thanks, Michelle. Doctor, can I call you Mo? Is that all right?
Yeah, sure, yeah.
Thank you. So, everyone else is. So, I mean, I think what I liked about the report is that it reflected a sort of voice coming through what people needed in a very practical way. And I hope that clearly is the case and that can continue. Any comments you want to make, Mo, on what John or Michelle or anyone else has said?
Yeah, just to echo what Michelle was saying, actually, that and John, that if we can develop it into the culture, and that is happening, and that one of the reasons why I joined the Humber Trust was that the teaching was really on point, and it was bespoke, and it did listen to the junior doctors, and it is of a high standard. So, if that culture can develop and continue, and we can then train up our staff so the on-call become less stressful because they're developing a skill as they're going along. So I'm really excited to be part of this, and I've seen lots of change happening whilst I was a registrar here and then became a consultant. So I think these green shoots have got really good roots. So I'm excited about how this is going to proceed.
Thank you so much. Thanks very much. Have a great day. Okay, Thank you for being with us. Okay, moving on then, we move on to the Safeguarding Annual Report, and I think we've got Rachel Sharp, Head of Safeguarding, with us, I hope. Rachel, yes?
Hi, yes, good afternoon, everyone.
Good afternoon, Rachel.
Good afternoon. I'm going to share my screen, if that's okay. I've got a bit of a presentation. If you could just let me know when you can see it. How's that? Can you see that?
We've got it.
Fantastic. Yeah. Technology's working. So I've met most of you before. I think my name's Rachel Sharp. I'm the named professional for safeguarding adults here at Humber and the MCA and Prevent Lead. You've seen the Safeguarding Annual Reports. I just wanted to pick out a few of the key themes and successes and challenges we've had across the year. So as with most services, we went from working in office to working from home. And of course, that presented some challenges and opportunities for us. Some of the challenges were that we had to continue to deliver our safeguarding duty desk, which was so important at that time as well, considering the amount of safeguarding concerns that we had around children and adults at that time. But it also provided us with an opportunity of being more flexible and being more available for more of our services across the trust, especially those up in the North Yorkshire area, where normally we'd be travelling up there in car to go and see them, or just talking over a telephone rather than seeing them through virtual means. So it's been a really, really positive experience moving to working from home. The team has gone through a number of challenges over the last year, a number of changes. We've had 3 new staff that have actually joined the team, and we've inducted them really well through even through the working from home arrangements, and we have a vast amount of knowledge and experience throughout the team. Looking at our children's referrals, we have had a reduction from our previous year of reporting of children's safeguarding referrals, and some of that is because of the lockdown periods that we've had. Children, of course, went to working from home as much as us that are employed did do, therefore there was having less contact with those external services. But for us as a safeguarding team, that made us more worried and concerned about actually what was happening for some of the most vulnerable children within our community. Children and Learning Disabilities Division has continued to be the highest reporting division across the Trust, and neglect of children remains our highest reporting over the last year as well. Adult referrals, as with children, have fluctuated over the last year, and again the reasons for that are around the COVID-19 pandemic, and that also supports with what's going on nationally as well. As expected, mental health has been our highest reporting division, and what has been really successful over the last year, and I think some of that is through the virtual means, is our engagement with the primary and community care division, and the number of contacts that we actually have through our duty desk from them. So that's been really, really successful. Duty contacts has increased significantly over the last year. We noticed a massive increase in those contacts to us, and again that's across from all the divisions as well. As I touched on with children's safeguarding referrals, neglect has come through as one of the most complex and one of the most challenging, and when we look at children who were at home, we talk about hidden harm, and that hidden harm is those children that are at home where they're not accessing external services, and people are not having access to seeing them. So we did a real focus on neglect and looking at how we can support our services and identifying what neglect is. And part of that is the rollout of the graded care profile tool, which I'll talk about later on. Ladder, we have to mention the ladder, which is the local authority designated officer and persons in a position of trust. A huge increase in contacts to us across duty, and also to me as the named professional for adults, and Kerry, the named nurse for safeguarding children. Not only has the pandemic affected the people we work with, it affects our staff as well. And of course, we've had a number of been involved with a number of concerns where there has been some concerns about our staff working with some of our patients, but we're fully embedded in that process in terms of identifying any safeguarding concerns. Just wanted to talk a little bit about the closed cultures. I'm sure you're all aware of the recent publications identifying and responding to closed cultures. Us as safeguarding team are fully embedded in looking at that, and again, the COVID-19 with the virtual means, you know, the lack of visits from family members and external services coming into the care homes, coming into our inpatient units. We needed a real focus on making sure that we was embedded throughout all the processes across the trust. So we're involved with the long-term segregation reviews, the initiation of those long-term segregation reviews. We're involved in extended seclusion reviews and CAFO reviews. We've continued to visit some of the inpatient units to see the staff, to see some of the patients. We've continued to support via our duty desk, and we've been an integral role through that clinical advisory group as well over the last year, and the ethics committee. We've sat on the ethics advisory group as well. Domestic abuse, I'm sure you're all aware of the increase nationally of domestic abuse. Again, talking about that hidden harm like we have with children, hidden harm with those victims of domestic abuse, where victims are at home, significantly more with the perpetrator having a lot more control over the victims. We identified that this was going to be a real concern with the pandemic, and we had a really good response to that. We've gained white ribbon accreditation in November of last year, so we're coming up to a year of being with that white ribbon accreditation. We've delivered multi-agency training, and we have domestic abuse champions. We've just recently revamped our domestic abuse policy to start looking at routine and targeted inquiry. And as a result of that, we've seen a really positive, I say positive, it's not positive for the victims, but at least we're identifying and responding to that domestic abuse. And we've seen an increase of 7.34% for our adult contact, and children 2.36%. And it's not just people aren't just coming to us with physical abuse, which is what predominantly we would get before. Staff are recognising different forms of abuse, such as coercion and control, such as gaslighting, etc. So that's really, really positive. Just touching on some of the concerns around children's safeguarding and CAMS, we've been really involved with some of the concerns around finding placements for children. We know that we've seen unprecedented amounts of children suffering with mental health problems as a result of the pandemic, and we've been working as part of a multi-agency to try and support these children and young people into the appropriate placements. So our named nurse for children has been working really closely with Inspire and the ISPINs and the CAMS teams. Lots of challenges with social care, because again, they have seen unprecedented amounts of children, looking at the looked after system and finding placements for those young people as well. So it's about working together to be able to support that. We're fully embedded in trying to support those young people that come through onto our adult inpatient units. So we're alerted straight away to a child being on an adult inpatient unit, and we will make contact with that unit to make sure that that child is supported as they should be as per children's processes, and also offer that extension of visiting them if they feel they need that. And just looking at the priorities for the next year, we want to continue with our domestic abuse work. We know we've had the Domestic Abuse Act that gained royal assent back in April. We've just revamped the policy and we've made some changes to that. The legal definition of domestic abuse is in that. And we've also made a specific focus on staff who suffer domestic abuse as well. We want to continue to increase the awareness of children's neglect. So we now have 2 trainers in the team who do the graded care profile training, which is about identifying and responding to children's neglect. And we're looking at some multi-agency training across the partnerships to deliver with the trust and also to deliver with the local authorities. We want to enhance our relationships with our primary care, with our GP practices. We've got a safeguarding lead working with that, offering them drop-in sessions to build those relationships and to look at how we can support them with safeguarding and also the training. We have ongoing challenges with compliance with our mandatory safeguarding level 3 training, which I'm sure you're all aware of. So that's another key focus for us going forward. And we want to promote the use of safeguarding supervision as well. What we're trying to do is make safeguarding supervision the norm, not just an extended conversation. For us, safeguarding supervision should not be anything different to what we're doing within our normal supervision processes. And we want a bigger, we want to be more involved with some of the EMI groups, the BAME groups, the equality and diversity groups. We want more of a presence on that as well. And just to say as well, working quite closely with PACE, we're trying to get some PACE volunteers to work with us as a safeguarding team to make sure that patient's voice is embedded throughout our safeguarding processes as well. And that's it. Thank you. I'll stop sharing my screen.
Thank you, Rachel. Thanks for that. And I know from the comments box, colleagues really appreciate the work you and others have been doing to, I think as you sort of suggested there, that safeguarding is just embedded in actually just how we look after people and care for people. It's part of the norm of what we absolutely do. So thank you very much for that report. Any questions? I can see Hillary's hand up. Hillary. Oh, you're on mute, Hillary.
Not a question, but as the exec lead for safeguarding, we chose to put the PowerPoint because we thought that the breadth and depth of safeguarding, you know, reading it in a report, you're not really going to get the feel of it, and particularly in the year that we've just had, like infection control, the pressures on the safeguarding team have been immense, and quick to recognise that this different world we suddenly entered without any plan. The impact it was going to have on safeguarding, suddenly everybody going into lockdown, and the team were very, very quick to respond to that, as were the clinicians as well, realising that in lockdowns, safeguarding now the pressure's on, we've got to really raise awareness around that and think differently about how we safeguard people within that context. So again, for me, well done to the team, thank you to the team, the flexibility, and I think as John's put in the chat box there, Rachel leaves us at the end of next month for pastures new, and you will be very much missed, certainly from myself. Safe pair of hands, Rachel, and you're going to be hard to replace.
Thanks, Hilary. Peter.
Oh, thanks, Caroline, and thank you, Rachel. A really comprehensive report there on you're doing. I'm sad to hear you're leaving, but you know, it's such an important area, and you're giving us such good assurance that you know, these things have been handled very effectively from the trust point of view. I was just going to pick up, because you did mention that neglect, particularly children's neglect, was one of the main areas, and you know, it would be nice to see that was improving, and you know, we're doing our best. But in terms of the environment that we're living in and facing winter now, you know, we've got parents possibly coming off furlough and not being sure whether they've got a job or not. We've got changes in universal credit, which could adversely affect some families. We've got fuel prices going through the roof, which could impact on families' ability to feed and look after children. So it seems to me like we've got quite a lot of issues in addition to the pandemic and everything else. So there's a lot to cope with. So you know, your team will be, I'm sure, be kept well on their toes. But I'll just say that the environment we're approaching now in the winter is going to be a difficult one. And you know, good luck to the team in helping our patients deal with that.
Thank you. Yeah, absolutely.
Thank you, Michelle.
Thank you. Just quickly, great presentation. It was good to have a bit of a slide deck actually, because there's a lot in the report, and thanks. And we'll miss you, Rachel, and all the best for the future. Just, I know that Hilary is really actually supports you. There's a great supportive mechanism, but if there's anything else, because obviously these are particularly difficult roles to have at the best of times, but the blended approach sometimes doesn't always work for that. But I know we've had a lot of conversations about that, but just thank you. And if there's anything else you think we can do from a pastoral support for the team or anything, then please let us know. But all the best for the future as well.
Thank you very much. Thank you.
Thanks, Rachel. All the best from all of us, and thank you. And yeah, I hope the work will continue and be a legacy of what you've contributed to us as well. Thank you so much.
Thank you. Thanks, everyone. Bye.
Bye. Moving on then, we have the review of the Standing Order Scheme of Delegation and Standing Financial Instructions, and that is, who's leading on that?
Me, Chair.
Oh, sorry, Michelle, yes, thank you.
Okay, so the annual review of this key corporate document has been brought forward from November so that we can ensure any changes required in relation to the go live date of the provider collaborative and the commissioning committee are reflected in the document. So the key changes are additions to various sections to reflect that the activities via the provider collaborative should follow the same principles as the trust. And these changes are namely in the two areas outlined in the report in sections A and B, in addition to some updates in relation to references to the commissioning committee and some minor formatting issues. In addition to the proposals in the paper, as discussed earlier, we also need to update the description of the commissioning committee to include 2 non-executive directors now, not the one that's actually in there. And finally, one other change is, as agreed by board last week, approval to change references to the name of the commissioning committee to the collaborative committee.
Thank you, Michelle. Everybody in agreement with those changes within the paper and the ones that Michelle's outlined? Francis?
Hi, Chair, thanks. A couple of points. Michelle did raise last week, which I think was a good point, the name commissioning rather than, and I just wondered if that needed to be put into here, because we talk about the commissioning committee, and I thought Michelle did suggest that we maybe change the title of that. So that was just one point. I don't know if Michelle wants to pick up on that before I go on. Yes,
Francis, I might have spoke very quickly, but I did say we also need to reflect those changes that we agreed last week.
Sorry, I missed that. The second one was that I just picked up that when you get to pages 366 onwards, it's a while since I've read these, since the last time they came to us, obviously. That there seems to be, and it plays back to a discussion we had earlier, that with the committees, Quality Committee and now Commissioning talk about providing assurance, which is great, but none of the others talk about providing assurance. And that's what they are, they're assurance committees. So I just think it needs sorting so as a consistency in those descriptions of what those committees do, that's all.
Okay, so with everybody's agreement, if we can minute that change will also be reflected, and I'll add the assurance element to make sure we're consistent, Francis.
I think thank you for that, Michelle, and thank you, Francis. Peter. Oh, you're on mute, Peter.
I'm on mute. There we go, off mute. Yeah, thanks, Michelle. I just wondered whether, since the last time we reviewed this, we've got a new sort of type of non-exec director, an associate non-executive director, and I just wondered if we ought to have a paragraph in about slight differences in a role of an associate non-executive director compared with a fully voting, if you like, non-exec director. Whether that needs clarifying in there. And the other thing is, just on the commissioning committee, I know you're going to change it to 2 non-exec directors, but we've also got some executive directors who are on that committee as well.
Yeah, we tend in the standing orders not to, I don't think any of the other committees reference executives, do they? But again, I will check it for consistency.
Thanks, Michelle. Mike.
Yeah, Michelle, just on the scheme of delegation, I do remember when I first joined the Trust, giving to either you or Jenny Jones the delegated power that we referred to earlier in the meeting about discharge, but that seems to have dropped off, but that's definitely a board delegated power. Can we reinstate that, please? And if you need the wording, I can let you have it.
I'll check that, Mike. It's not been taken off deliberately, so whether it's a formatting issue, but I'll definitely compare it to the previous filter.
Yeah, okay.
Thank you. And Michelle, you took on board the point about the associate non-executive director as well, reflecting that somewhere. Great.
Yes, I've got it. Thank you.
Thank you. Thank you. Any other comments? Well, thank you for all of those contributions. If everybody is happy, acknowledging the points that have been raised, and Michelle is going to go away and make sure we've got consistency, can we approve that report? Yes? Thank you. Okay, we now move on to the framework for quality assurance for responsible officers and revalidation. And John.
So, Chair, I'm mindful of the comments earlier on about the amount of paperwork coming to board. So just to say, this has been through the Workforce and OD Committee who have approved it. And it's merely here for the board to ratify and approve it so that Michelle can sign it and submit it.
Okay, thank you very much. Any comments? Is people happy to ratify and approve this document? Yep, thank you very much. Moving on, 29, the winter plan, which there was some detail in the Chief Executive's report on this, but Lynn, you're going to follow up.
Yes, thank you, Chair. I obviously assume people have read the report, but just in a quick summary, I guess this report overall is a composite summary report below which sits a number of detailed service winter plans. Obviously, winter planning takes place obviously both within our organisation, but obviously across our system partners as well. There's a number of arrangements that have been in place and happening already. There's further work to take place. We submit our plans centrally to our CCG colleagues and through our ICS2. Through that process, obviously, there's a number of sort of workshops that really focus on stress testing these plans sort of through the scenario planning process that you would expect to see. I guess if there is a benefit, and we have been focusing on that today, that, you know, following on from what we have learned and experienced through COVID, all of that learning has been obviously taken forward in developing this year's winter plans. I guess despite that, we are expecting this particular winter to be challenging because we're already seeing challenges across the system now without the impact of winter. But I guess we've done our utmost to prepare for those. I think overall as well, we've learned quite a lot through COVID, more so than we had previously, around the benefit of mutual aid. And we've really worked hard across the mental health system around that. So again, that's a good premise to have developed our winter plans from. Our key challenges are the ones we've already touched on today. Obviously, the availability of our workforce. We've already got a system under pressure in terms of the acute hospital trust, the recovery of the elective programmes of work, the impact that has on our services, and the pressures particularly across local authorities and that fragility across the provider market that we've already touched on in the COVID update too. So all of that has been taken into account in our planning. Obviously, the other typical areas that you would expect to make sure that we're prepared for around adverse weather, the flu campaign, this year, obviously the COVID vaccine booster programme, all are elements of the plans that we've developed. So I'll leave it there, but obviously very happy to take questions.
Thank you, Lynn. Any questions to Lynn? Okay. Lynn, thank you for that comprehensive report and Claire's work on that, Claire Jenkinson as well. Obviously, John put in the chat box, we've been living through a winter plan, particularly for the last 2 years. So, Peter, sorry, Peter, I missed you there.
No, I was just going to ask a quick question for Lynn. In the distant past, we have supplied some surge beds in the winter. Would there be any capacity within our bed base or within our estates to offer that or to be involved in providing surge beds if needed to the acute sector, if you like, over the winter?
I guess to answer your question specifically, obviously we have had reduced beds at both Malton for various reasons, and obviously through the situation with the redevelopment of Whitby Hospital. So with the transfer of the ward back now to its new position and estate, obviously that means that we've been able to increase the beds, Peter. So I guess, we, for the reasons that we've already discussed in relation to the out of area position, our plans are to maximise every opportunity to have as much inpatient bed capacity as we possibly can. And that's indeed what we have done through what I've discussed so far today. So I think beyond that, we have, looked long and hard. We will have that maximum capacity. I guess the other, issue is, again, the workforce challenges are real challenges for us, Peter, but we have taken those obviously into account as well. But obviously that'll be an area that we continually look at. It is a conversation that's happening across system partners. There's been, obviously, as you would expect, quite detailed work about actually what would the type of bed be that would really support that position. So there is some developments that are taking place across our system, not necessarily provided by us, but other partners to support that.
Thank you.
Thank you, Lynn. Anybody else? Michelle?
Yeah, just to build on that, because it's a really good question. I mean, obviously, our main focus is to keep people in their home as long as possible, and actually not necessarily increase bed capacity, though I know sometimes we have to do that. So as a system, we're looking to see what else we can do in relationship to capacity for supporting care homes, supporting the local authority, particularly because the local authority particularly is under immense stress, and as we know at the moment, from workforce, etc. So we'll continue to do that. And as Lynn said, the main aspect in relationship to that is obviously workforce as we go forward. We have got some plans on the shelf if we need to, if there's any extra allocation money that usually comes out with little time to, have you got a plan, just implement it, here's the money. So we are thinking ahead in relationship to that. But it is more, I think, a whole system approach. We've already had one system meeting in relationship to winter, and we're doing quite a big piece of work on mental health, particularly about how we continue that mutual support, that learning that we've done through COVID, and how we maximise that as we come into the winter months. But I mean, I think as we've all said, we've not really been out of this precious situation. And as I said to some folk yesterday, we're in winter, we've been in winter all the way through, to be honest. So it's just a different surge. It's just a different type of challenge that we've got, but we'll continue to plan for it as best we can.
Thank you, Michelle. Thank you for that report, Lynn. That's received and noted. Are there any items for escalation? Nope. Great. Any other business? Nope. Great. So at this part of the proceedings, for those of you watching, we're moving to part 2. That's a private part of the board meeting. Members of the public cannot form part of that because of the confidential nature of the business to be transacted, and publicity of which could be prejudicial to the public interest. So goodbye to those who have joined us today. I hope you found it interesting. The next board meeting is on the 27th of October at 9:30. Thank you for joining us, and thank you for all those colleagues who've joined us today and shared with us the work they're doing across the Trust and for the people that we serve. Thank you very much.